Welcome to the Functional Medicine Foundation's podcast, where we explore root cause medicine, engage in conversation with functional and integrative medicine experts, and build community with like-minded health seekers. I'm your host, Amber Warren. Let's dig deeper. Hi, everybody. Amber Warren here. We just wanted to present a little, not necessarily a disclaimer, but a little adjunct dialogue to our podcast that includes the discussion of thermography. I'm inviting our Chief Medical Officer, Dr. Mark Holthaus, to discuss all things as it relates to using mammography versus thermography, even versus things like ultrasound that we discuss, to detect breast cancer as soon as possible. Breast cancer is the number one cause of cancer death in women globally, and early detection through any kind of imaging screening has found early stage cancers more often than just potential cancer production from the test itself, specifically in mammography. We know that there are concerns with radiation when we're using mammography as a detection screening tool, but the devil is always in the details. Regardless, we are recommending a multimodality screening approach that involves thermography, whole breast ultrasound, and mammography. And combining all of those three tools, we know is the most ideal approach to early detection. So please listen in to Dr. Holthaus as he kind of balances the other side of the coin, so to say, and discusses mammography and the shortcomings of any one imaging tool when it comes to detection of breast cancer.
Hi, this is Dr. Mark Holthaus, Functional Medicine of Idaho, wanting to share a bit of my perspective on the clinical safety and efficacy versus downsides of mammography in the context of thermograms and breast ultrasounds. A lot of female patients are concerned about the amount of radiation they receive over a lifetime of screening with mammography. The current studies show that with the more modern technologies, the more recent scanners using digital technologies has much fewer ionizing radiation exposures relative to the old film and screen-based machines. The screening has saved countless lives by finding cancers earlier and making them more amenable to successful treatment, as opposed to missing the opportunity and finding them at a much later stage. Other technologies such as thermography are available for looking at thermal imaging and heat signatures, which can find inflammation sooner and even before cancer's development has taken a hold, but they don't find the microcalcifications of early cancer that are seen with mammography. The actual incidence of breast cancers induced by the radiation received over the course of a lifetime is variable based on size of the breast density, and how frequent the mammograms are being done. The current guidelines are from age 40 to 74 every 2 years for average risk women. If you have a strategy where they start at age 50 and go to age 74 every other year, the number of breast cancers found to occur per 100,000 women drops significantly just with initiating the initial mammogram at an age 10 years later. Breast tissue is more sensitive to ionizing radiation in younger women, and so that is one of several reasons why we don't do mammography earlier in life. That and the problem with false positives, where you're going to find a lot of glandular tissue that makes it difficult to delineate or see clearly normal from abnormal tissue. The newer mammography machines are much better at getting higher resolution, which leads to fewer callbacks and fewer additional images, which in the past have often added to the radiologic burden. The current amount of exposure with a single mammogram is equal to what you would be exposed to just walking around outside over about an 8-week period. The number of breast cancers that are estimated on average per 100,000 women from mammogram is thought to be anywhere from 6 to 30 per 100,000, but it's highly variable, again, on the frequency of screening, the size and density of the breasts, whether or not it's a screening or a diagnostic mammogram, where there are additional views on the diagnostic side. Thermography is a wonderful addition that can be used as an adjunct to mammogram and or ultrasound in certain scenarios, looking for these areas of inflammation that can be followed, and if they're abnormal, further testing can be done. We're looking for standardized processes using artificial intelligence that will improve the technology. And I'm hoping that someday it will maybe even supersede mammography as a screening test that the FDA has approved. Mammograms have a high false positive rates and even false negative problems where they miss things when the breasts are dense. And so whole breast ultrasounds can be a great addition to mammography when used as a screening tool. It is important to know that ultrasound, whole breast ultrasound as a primary screening modality, is fraught with problems and considered dangerous in that it has such a high false positive rate that it can commit the client to needing unnecessary mammograms. It's best to be used when there's a palpable mass that you can feel, or in the case of dense breasts with mammogram, where its sensitivity is improved over mammogram alone. We believe at FMI in a multimodality approach that's individualized and based on the patient before us, based on whether or not they're taking hormones or not, whether they have dense breasts, large breasts, their age, what is their breast cancer risk, as to which of these modalities makes the most sense. Always balancing risk versus benefit, trying to find cancers early versus avoiding overtreatment and overdiagnosis. Hopefully this is helpful. We'd invite each and every one of you to come in and have an individual discussion about what multimodal breast cancer surveillance looks like on a one-on-one basis so we can tailor a program for you. I think it's important to not throw out any one modality as always bad or always good, and realize that it's the individual application for the individual's needs and specifics that matter. Thank you very much. Hopefully this is helpful.
Welcome back, everybody. We're here with Dr. Philip Hoekstra talking about thermography. So Dr. Philip Hoekstra is a pioneering leader in the medical thermography whose decades of research has revolutionized the use of infrared imaging in early disease detection, especially in breast health. Inspired by his father's Cold War-era infrared work, Dr. Hoekstra began experimenting with thermography as a teenager and went on to earn his PhD in neuroscience from McGill University, completing advanced fellowships at Georgetown, Temple, and USC. As a past president and lifetime fellow of the American Academy of Thermology and longtime director of Thermoscan Laboratories, he has set international standards for thermographic analysis and continues to advance the science of medical imaging through innovation, research, and education. We are so thrilled to have you on our podcast, Dr. Hoekstra. How are you?
Doing very well. Thank you, Amber. I'm pleased to be here.
Yeah, we've been working together for, has it been 3 years? 3.5? Yeah, offering thermography out of our clinic in near downtown Boise. And just last year, we launched, we're now doing thyroid imaging, thyroid thermography, and that's been a really exciting thing to add to our field. So can you just share your journey and how you got involved in this field? Because clearly you are an expert in this field and highly respected.
Thank you for that. It's been a rather long journey. As you
Yeah.
indicated, I started this as a teenager. I'm actually second generation in this field. My father was one of the pioneers in the development of the equipment and its early application into medicine. He wasn't among the very first at that, but where he had the great depth was in the knowledge of the equipment, and also the fact that he was a scientist and not able to do any type of evaluations by speculation or guesswork. We had to have a defined, objective analytic method for everything that we did. And that was really something fundamental to transforming thermography, which is still the common word, to a derivation of that, which I use more distinctly, which is thermology. When you apply the scientific method to what you're doing, when you have objective and quantified standards, when you understand the mechanisms, the basic pathophysiology for the things that you're looking at, you really transform this from an empirical thermography to the more scientific thermology. But my father was instrumental in developing the infrared imaging systems that were put into satellites. And for many years, he was working with people in the intelligence community during the Cold War. And for whatever era we want to talk about that we're in now, whether it's global war on terrorism or whether it's evolved to something else, the Cold War was a decidedly weird era too. Full of secrets and black bag projects. He had one of the most enviable things for any scientist, which is an unlimited budget. And certainly he found all kinds of ways of spending great quantities of money. And the satellites that he developed, the systems for the satellites, just have absolutely amazing capabilities. But by the late 60s, he had a belly full of working with the intelligence community. One of his favorite lines was, "I don't know who to be more concerned about, these guys or the KGB. They're all crazies." So he took a contract from the American Cancer Society, which was at that time looking into breast thermography as it was being developed by such notable people as Jacob Kirsch-Cohen, who was really the one of the two fathers of mammography in the U.S., and a number of other people. And he saw a great future in this type of thing. A tremendous point of development, and made the leap away from the intelligence community as we started Thermoscan together back in 1972. And Thermoscan was the first freestanding thermographic facility in the world. And our specialty from the beginning was in doing evaluations of images. So very rapidly, we set up a reference laboratory where people who had equipment, such as what's in Functional Medicine of Idaho, was sent to us for what is our thing, the analysis and reporting. Now, based on some of his initial contacts, I was able to get into fellowship programs at some major academic centers. My first was at USC in LA, where I worked with some very notable people in vascular thermology. From there, I went to Georgetown and worked with people in neurologic thermology, and was also part of the infamous breast cancer detection demonstration project while there as a ghost interpreter. From there, I had the good fortune of working with Harold Izzard, who was a professor of radiology at Temple University. And he was a protege of Jacob Kirsch-Cohen, and learned a lot of his methodology in terms of breast thermography. And from there, went to McGill University and worked on some more of the neurologic applications of this. And one of the more notable moments was when Dr. Izzard was very frustrated with me because I kept asking him endless questions of how one study was normal and another one was abnormal. What features was he particularly looking at? And out of frustration, he put his hand on my shoulder and he says, "Okay, Phil, now it's your turn to turn this into a proper science." And I took him seriously.
Yes, you did.
And a tremendous amount has been learned in terms of the basic pathophysiology that explains the heat signatures that we see that are related to breast cancer. And I'm pleased to say that ThermoScan has been in the forefront of developments in terms of incorporating that science into analysis to be able to deliver it for patient care. So it's in some ways it's been a very exciting ride.
Mm-hmm. Mm-hmm. That's exciting. It's fascinating history. So can you break it down for our audience? What is thermography or thermology?
Sure. Well, let's start with thermography, which is the earliest version of this. Thermography is really enabled by the development of infrared cameras. Infrared is beyond the ability of infrared is a portion of the electromagnetic spectrum that's of longer wavelength than red, hence infrared. First discovered in 1800 by Sir William Herschel, when he discovered that with the use of a prism, he could heat something outside of the visible spectrum when he put some sunlight through a prism. But technology came up with a means by which to visualize infrared and turn that into images that we could work with. And it really is a new extension of the human experience to be able to see something that is outside of our senses otherwise. I mean, it's basically the equivalent of the taste of a sound or the touch of a feel. Thermography was, because of the high-tech equipment for this, initially part of a secret government project, and medicine was the first application for that. So basically what thermography is, medical thermography, is imaging of human beings for diagnostic purposes using this special extension of human senses through the electronic cameras of an infrared thermograph. Initially, the people who were working in this, and the real pioneer at this was a fellow by the name of Dr. Ray Lawson. He was a professor at McGill University in Montreal. There's a long story as to how he got his first thermograph. The appreciation for heat in medicine goes back to really ancient practices in medicine. It's written up in the Book of the Yellow Emperor. The physicians of the Pharaoh era of ancient Egypt appreciated the importance of heat in medicine. Hippocrates himself canonized the evaluation of heat, body heat, as a cardinal sign of disease, calling it calor. And while it may have sounded a little better in Old Greek, he is quoted as saying, "Wheresoever in the body excess of cold or heat is to be found, or is detected, there disease is to be found."
Mm-hmm.
And physicians of his era were known to paint a thin slurry of mud onto the skin surfaces of the patient and observe different levels of drying as an indication of abnormally cool or abnormally hot pattern features. We probably couldn't get such a thing past the FDA these days as a new medical device. But the electronic thermograph is something that has been sanctified by FDA and is cleared as a medical device. Dr. Lawson had been doing experiments on his patients with known breast cancer, where he had discovered that the skin over the top of the cancer was hotter than other areas of that same breast, or certainly other areas in the opposite breast. He had no idea why. It was an observation at that point. So empirically, when he had the electronic thermograph, he could see the heat. And by seeing this occurring in enough patients, he knew there was some type of connection there, but he didn't have a clue as to what that connection might be. So he theorized and thought that, well, it may be cancer because it's uncontrolled growth, and heat is a byproduct of metabolism, part of that growth. Maybe that's why we're seeing the heat patterns related to cancer. It was a good guess, but it was wrong.
Yeah.
And a friend of mine at Southern New York University, Mike Anbar, did a really elegant calculation by which he was able to show that, no, that can't be. In order for a 2-centimeter tumor to maintain 2 degrees hotter temperature than the tissue around it, given the washout rate of blood through typical breast tissue, it would use up about half the caloric content of a person's food in a day. So that clearly isn't the case. Mm-hmm. And it's been discovered that the heat that we see is because of unregulated blood flow of core body temperature. And I could get into that in raptures. It's one of my favorite topics. But the bottom line is that part of the basic physiology or pathophysiology of cancer explains why we see the heat patterns. And we know that it's a reliable indicator of the presence of cancer. Especially when you get into things like dynamic testing. But thermology, when we apply all the sciences to this, and we do this in an objective way, is part of that transformation from thermography, which is simply sort of like photography, making pretty pictures and guessing what it is we're looking at, to doing a proper analysis and evaluation on an objective and repetitive manner. One of the big differences between thermal imaging as used in thermography and thermology, particularly thermology, over mammography, is that mammography doesn't work with any real world units at all. It's not like so many ergs per cubic millimeter. And the evaluation of mammograms is strictly from the perspective of pattern recognition. In other words, you look at something and you try to discern its structure by the features that you're seeing. And mammography in all of its forms, film, digital, or stereotactic, is an X-ray of the breast. It's evaluating the tissue, breast tissue, by relative temperature or differences in tissue structure. And one of the issues is that it's really compromised under a lot of circumstances. The effectiveness of mammography is greatly compromised when women are built unusually big or small. They have fibrocystic disease of the breast. They take hormone replacements. They're pregnant, nursing. They've had breast reductions or implants. They've had prior biopsies, or the biggie, dense breasts. Half of the women have dense breasts these days, and the overall effectiveness of mammography is very low at that. Under the best of circumstances, the very best, mammography has a sensitivity of about 80%. From a practical that means that 1 in 5 cancers is being missed. From a more practical standpoint, the sensitivity is usually gauged at about 60%. Where mammography is really failing is in terms of specificity. And I'm sure that you've seen many of your women patients who've had biopsies, and we'll call them needless biopsies because a mammogram was calling something of concern worthy of biopsy when in fact it was something else. So the specificity of mammography is rated at about 19%.
Mm-hmm. I believe it.
A thing to be proud of.
Do you have any data? Sorry to interrupt you. Do you have data on the sensitivity and specificity of thermography?
Funny you should ask. Yes.
Good. I was hoping you'd go there.
We do operate the most experienced laboratory in the world, and we did a clinical study, an outcome study, a few years back, where we were able to demonstrate a 96% sensitivity and a specificity of about 84%. Not perfect. But these were standalone results. These were women that were followed for 6 to 7 years with the notion that if indeed we had missed something in our initial study, 6 to 7 years later, it would likely have emerged from some other means of evaluation. This was published and peer-reviewed. I really think that with more development, we can do better than that yet.
Yeah.
Thermology is much more objective than mammography. It doesn't. It's not really a subjective means. It's certainly not the way that we do it. And I'm also one of those obsessive compulsive people at this, that if I can figure out a way to do this 1/10 of 1% better, that I'm going to put full effort into doing just that.
What is your response to women that have concerns about the radiation when they undergo mammography?
I have concerns about that too. Breast tissue is exquisitely sensitive to radiation, and the effects of radiation are cumulative over time.
Right.
If you get a mammogram every 10 years, the effect of the radiation is cumulative over time. And I think that there's not a general awareness, certainly among the medical community, as to the harmful effects of radiation.
Now, you said a mammogram every 10 years.
I'm sorry, I misspoke. One
Okay.
mammogram every year for 10 years is what I meant to say. Thank you.
Yes. Okay. That's what I said. Well, yeah, I figured that's what you were assuming. But then we also have these patients who are then with dense breast tissue. It's being recommended that they go in for diagnostic mammography every 6 months or for a 6-month follow-up. So there's actually a lot of women that are being exposed way more than just once a year for a decade. And I agree with you. It's the cumulative exposure, and it's not just a mammogram, even once a year. It's also all the EMFs we're being exposed to and the microwave waves and the exposure from our laptop computers and cell phones. So it's no longer just an X-ray or a mammogram once every few years. It's just this total radiation exposure that we're experiencing.
Well, it's very clear that breast cancer has a multifactorial root to it.
Right.
If we went back 150 years ago, the incidence of breast cancer was remarkably low. And that's not because it was being underdiagnosed at that stage.
Right.
Then 1 in about 50 women was being diagnosed with breast cancer in their lifetime. And currently, we're at the precipice between 1 in 7 and 1 in 8 women, with an increasing incidence. We'll be at 1 in 7, unfortunately, sometime fairly soon. And it used to be that if you weren't yet 65, you really didn't have to worry about any incidence of breast cancer. That's changed remarkably too. The increasing incidence of breast cancer is largely being borne by younger women. In our facility, we've had several instances of girls as young as 14 being diagnosed with breast cancer.
Yeah.
And while that is extraordinary, we're seeing horrible numbers of women into their 30s and 40s being diagnosed with breast cancer. This is not just an abnormal study from us, but this is ground truth from pathology.
Mm-hmm. Why do you think that is, Dr. Hoekstra? Why do you think we're seeing younger and younger women? I mean, 14, I have very few words in response to that.
The nature of the disease is changing as a result of the nature of our lifestyles. Mm-hmm. There are so many factors into this. The common use of, the abundance of different plasticizers and carcinogenic chemicals.
Endocrine disruptors.
Yes, whether it's pesticides or plastics in our food, whether it's the use of pharmaceuticals, there are just many, many roots to the origins of breast cancer in every individual. And basically nowhere in the world is somebody living as they were 150 years ago when the incidence of breast cancer was so low. There was just maybe it was 10 years ago, there was essentially an epidemic of inflammatory breast cancer taking place through North Africa. Why? I don't know. There was something, whether it was burning oil wells there or what, I don't know. But the nature of the environment has very much changed us and put all women at much greater risk for breast cancer at younger and younger ages.
So correct me if I'm mistaken, the data is truly that thermology can detect cellular changes, potential of breast cancer 3 to 4 years before mammogram can, or mammogram could. Am I way off there?
No, you're not way off there at all. The numbers vary. It's virtually impossible to do a biopsy based on a thermology finding alone, because you do need to localize it specific enough to do a needle biopsy. And for that, you need some other means of indication. The most useful means of indication is a targeted ultrasound to match up what we're seeing metabolically with a structural feature. But there has been some very august centers that have that use thermology along with mammography, with ultrasound, and do biopsies there right on the site. And they've been able to demonstrate that thermology was able to detect breast cancer 5 years and more before it was evident any other way. Dr. Guthrie did that. Dr. Kaiserlink demonstrated this as well. There's others that have published on this. It's a difficult thing to say, but again, if you follow women in the multimodality approach, then you can come up with this as a conclusion.
Okay. I wanted to revisit a couple of the things you mentioned regarding insurance coverage. And I'm a big advocate and big proponent of patients being educated on the insurance world, especially the conventional insurance world, and being aware and informed of all the different, how do I say this, replacements for conventional insurance, right? These different health share plans. I hesitate to mention some of them, but I will. Samaritan Ministries is one, Liberty Health Share is another, MediShare is another. I don't have very specific recommendations on any of them. I've heard really good things, honestly, about all of them, but I think the important thing for our patients in our community and our nation to know is that you don't have to have a conventional insurance plan that dictates how you want to be screened for breast cancer or colon cancer, or how you want to spend your healthcare dollars, right? And so, because thermography is not expensive. It's not thousands of dollars. We're talking hundreds of dollars. And there are different non-conventional health shares and coverage systems that allow you to choose to spend your money that way. and are much more affordable than some of the more conventional insurance plans. So I think, our patients need to understand there are options that actually do support this way of screening and of preventative health care.
And
Right.
often we're too short-sighted on this type of thing. It doesn't cost very much for me to maintain my hair, but for most women, they'll spend far more than that getting their hair cut and colored and whatever.
Oh, yes, they will.
But the unfortunate thing is that breast cancer is a major problem, and if you're waiting on insurance to direct preventative care, and if you're waiting on guidelines to direct preventative care, you could be really headed towards a very sad outcome.
Yes. Well, and in that same breath, I've had such a difficult time in our community here in the Treasure Valley in Idaho, finding facilities that are willing to my patients that are aware of everything we're talking about, the radiation exposure and the shortcomings of mammography. I've had such a difficult time finding facilities that are willing, if we get an say we get a TH4, and then we know there's further imaging that's needed. A lot of these local hospitals and imaging centers refuse to do an ultrasound and consider a biopsy on these patients without a mammogram. And I have just been knocking my head against a wall for the past 3 to 4 years saying, why?
I really appreciate working with your group there, because I know that it's not cookbook medicine. There's actual thinking that takes place in the care of your patients. And I see that even on my more distant end for patient care. And it's one of the reasons I really appreciate working with you and your group.
Oh, thank you. Yeah, I'm biased. I think we have some of the most fabulous practitioners in the whole world. And obviously I'm very biased towards the field of functional and integrative medicine. And I just love what we do and love the whole body care we offer both men and women. So thank you for that. That's a huge compliment to us. Briefly, I just wanted to touch, I assume you have a lot of the same things to say about the thyroid thermology that we do and that you guys read as well. Same thing regarding, trying to avoid radiation to the thyroid gland and trying to identify early cellular changes to help detect thyroid cancer. Anything that's worth mentioning regarding thyroid thermology?
The thyroid seems to be increasingly under assault, especially for the female of the species. And things like Hashimoto's and Graves' disease, simple hypothyroidism are really only being detected at later stages. And there's a great deal that can be done to help women, especially women, but all people who have lesser degrees of thyroid disorders. Again, one of the nice things about thermology is that it is completely passive. Nobody's getting injected with radioactive iodine. There's no dye injections, no poking, no prodding. It's as harmful as having your picture taken, even if not quite as gratifying. But go ahead.
Oh, no, I wanted you to finish. I didn't want. I'm sorry.
We can pick up the metabolic features of the thyroid itself because it is so superficial, and we can also look for the signs of the autoimmune destruction taking place in the thyroid by looking at the activity of some of the superficial lymph nodes in through the neck. And if you've seen our questionnaire, I think we have a really good questionnaire for common symptoms. And it's amazing how many people will be marking off many of these symptoms. And in their own mind, they think it's just part of getting older or from something or another they've experienced, when in fact, these are signs consistent with thyroid disease.
Right.
So with a simple screening, we have a very good indicator. it should be done together with some blood tests, some blood markers.
Absolutely. Yep.
But that and the clinical features, I think, make a very good combination, diagnostic combination for picking up thyroid disorders in your patients.
And what are the advantages of thyroid thermology over a thyroid ultrasound?
Thyroid ultrasound can do a fine job of picking up things like cysts and maybe the physical size of the thyroid, but it doesn't tell you at all what the thyroid is doing. We can actually discern the metabolic features of the thyroid gland itself. And that's a lot more useful in terms of learning about the patient's symptoms and how well it's working than how it's structured. So
again, physiology versus structure, same as it's very similar.
Exactly. The oldest argument in academic medicine, and the anatomists and the physiologists don't usually sit together at lunch.
They don't. That is so true. I just so appreciate your wisdom and your intelligence and your experience in this arena, because it's such an exciting thing for us to be able to offer. And I want to just shout it from the rooftops, especially now during Breast Cancer Awareness Month. And I'm just so thankful for you and your heart for disease prevention. And thank you for your time.
Again, I'm one of your great fans and that of your staff. All the potential for the things that we've worked out in terms of academic medicine and diagnostic medicine don't mean a thing at all unless it's put into capable hands, the kinds of care that you're providing for your patients. And I couldn't be any more pleased that you're utilizing this in an effective way, and we really appreciate working with you and your patients.
Well, likewise, we so enjoy working with you, and I'm looking forward to a long, bright future of communicating and just helping people find wellness and heal.
Good stuff.
Yes, I love it. Okay, well, thank you so much. You take good care. We'll be in touch soon.
Indeed. A pleasant day to you and all.
You as well. Bye, Dr. Hoekstra. Are you looking for high-quality supplements? FunMedShop.com is carefully curated by the wellness experts at Functional Medicine of Idaho. You'll find high-quality supplements to support your health and optimize your body's natural functions. Rooted in responsible sourcing and utmost commitment to purity ensures that you're getting products that are not only effective, but also safe and reliable. Plus, you'll find our own line, Functional Medicine Foundations, which is carefully formulated using the best ingredients available so you can trust that you're giving the body the support it needs. Visit FunMedShop.com today and take the next step in your health journey. That's funmedshop.com. Thank you for listening to the Functional Medicine Foundation's podcast. For more information on topics covered today, specialties available at the FMI Center for Optimal Health, and the highest quality of supplements and more, go to funmedfoundations.com.